Today's talk will be on the scope of safety for clinicians beyond the traditional environment of care and life safety functions. We're grateful to the American College of Medical Quality for hosting these quality educational sessions that aligns with their mission to provide leadership and education to healthcare providers. Next slide, I will introduce you to our team today who will be part of this talk. First, to my left is Anthony.
Thank you, Andrea. Good day. My name is Anthony Pellicone. I'm the Vice President for Northwell for the Enterprise Safety and Regulatory Compliance.
Hi, everyone. Thank you so much for this opportunity. My name is Nicole Benincasa-Ragonese, and I am the Vice President of Customer Experience and Community Partnership for North Shore University Hospital, part of Northwell Health.
My name is Yosef Dlugacz. I'm a retired Senior Vice President at Northwell. I played a few more roles, but will not get into it. And currently, I'm a trustee at Northwell on the Board of Visitors and a board member of the American College of Medical Quality.
Hi, I'm Andrea Restifo. I am a member of the American College of Medical Quality. Here at North Shore University Hospital, I am the Associate Executive Director of Quality Management, and I mentor students as an adjunct assistant professor at Hofstra University, the School of Business. And we're very grateful to Brandon Coward, who is our Senior Associate for Finance and Operation, who has really provided a lot of technical support and taping of this. So thank you very much. The goal of today's program is to really describe how our health system, Northwell Health, has a safety program and what makes it unique and transparent with a just culture and a real strong focus on our community and workforce safety. We want to embed the principles of life safety and environment of care into clinical operations by creating programs that do prioritize the workforce safety, prepare for disruption of day-to-day activities, while continuing to prepare for each patient's individual needs and of different populations in our community. Our objectives today, we'd like to illustrate the safety concepts that are needed to be consistent with our safety management plans and the essential pieces derived from emergency management, utilities management, safety, security, and hazardous waste. We will demonstrate how the safety measures are used in clinical operations in a different priority areas such as workforce safety, needle sticks, and emergency management. We will describe the environment that the interdisciplinary education is conducted to foster communication, give immediate feedback, and drive continuous improvement for vulnerable populations as well as the community. And lastly, we will share how our program evolved to prepare clinical team members for new frontiers such as aging adults, environmental threats, and sustainability. We have a lot to cover today. Okay. All right. And I want to just remind everybody that we've done several educational series over the last couple of years. Dr. Dlugacz and I were thrilled to be here with Anthony and Nicole. But we're also thrilled to announce that our health system, as of 2 days, has expanded. Nuvance is part of Northwell Health, and we are now 28 hospitals. We have over 100,000 employees, over 1,000 ambulatory facilities, 11 magnet-designated hospitals. You can see the large capital budget, and the population we serve is 13.2 million people. Our community impact is $2.7 billion, and you can see our caregivers. We are plentiful, and also our operating statistics. We have a large amount of emergency visits, ambulatory surgeries, births. I believe this is one of the highest numbers in the country, and a lot of research that goes on. So when you talk about safety and patient experience, we're really glad to illustrate how the program works here at North Shore and how we're carrying out through the system. We'll turn it over to you, Dr. Dlugacz.
Yeah, it's really fascinating to see such a complex map. And my question to you is that serving 13.2 million residents across such a large and diverse geographical area, how do you keep the notion or the implementation of safety across the system?
Yeah, that's a great question. And being as diverse as we are, whether it's the geography and the population being served, we have a blanketed approach with it as a system, as a health system and the enterprise with a regional, local, and then really community-based, focused approach. We're going to elaborate on that a little bit more in greater detail in the coming slides.
What I think, though,
Yes.
is that there are different things that we can focus on in our system that relates back to safety, no matter what environment, and that's such things as fall prevention, medication safety, infection control, equipment safety. As we talked about in the goals, preparing for disaster, crisis management, data security and privacy, accurate diagnosis and treatment, and making sure our technology is reliable. So there's a lot of different topics that our safety and our hospitals focus in on to really drive a culture through Northwell.
And not just for today, but for the tomorrows. Obviously, with technology, everything Andrea just spoke about is that the different populations, the socioeconomics of those communities, whether someone is giving birth and coming into this world, end of life, or those in geriatric community. It's also about artificial intelligence and real forward thinking about how and what's being impacted in our society.
The bottom line is that you set expectation, the same expectation, everywhere where the name Northwell is. If it's outpatient, inpatient, upstate New York, downstate, it's the same.
Yes.
If you enter the organization, you get the same feeling of safety.
I would say we have a really proactive approach. We work really hard and are very mindful to not be reactive.
Great. So this leads to the next question. How do you define safety and what does it mean?
Building on the other question as well, like how do we define safety? I think that's very subjective in some ways, but our health system uses the following guiding principles to define safety, and that's patient safety first, safety always. And I think that this happens every day, but when we had COVID, for example, it was we need to make sure our employees were safe and the environment was safe. So safety is always, okay? We have the 6 aims from the National Academy of Sciences that health care must be safe, effective, patient-centered, timely, efficient, and equitable. And everything we do as far as developing processes and looking at outcomes are aligned to these 6 pillars. We have measures around all of this, and we are able to be transparent with our frontline team about these pillars. In any area, and this is quality and environmental safety, teamwork, open two-way communication promotes a culture of patient safety. I feel that if someone blocks an entrance because we have construction and we don't communicate that and we need to transport a patient, there's going to be a longer route. We're putting that patient in danger. So that communication is always important, no matter what it is, medication administration or related to the environment. Then high reliable is essential for patient outcomes. We, and we'll talk a lot about this, want the input from patients, employees that are in the front line to tell us what we can do better. They are the experts. We want to defer to them. And then we always prepare for things, and we know things are going to happen. Individuals are going to make mistakes, but if we can expect them and prepare for them, they'll be managed so much better. So these guiding principles help us define safety at Northwell.
And overall, safety in itself is very complex. It's not homogeneous, right? So it has to be, it's really a complex concept that's influenced across all the different areas and services that Andrea spoke about earlier. And it's about whether it's an individual, whether it's about a situation, or different groups, but it's all inclusive for our clinicians, our team members, our patients, and their families.
There's a science to safety and then there's an art to safety. And I think we are very thoughtful about marrying the two.
This is great. But to implement, I was thinking as you are talking about the definition, to implement such a complex definition, across so many organizations. You need the approval of senior leadership. So I think that the CEO bought it, and as sitting on the board for quality at Northwell, I see the same thing. I see the information on safety and quality coming up and discussed openly in a transparent manner, which is really wonderful.
We don't hold safety as just a word. We hold it as a culture, and it's truly woven in, not into being a bought perspective that someone needs to buy into it, but it's really woven into the fabric of their intrinsic values across the organization, from the CEO to our clinicians to those that do not even have direct patient contact.
So before we go to talking about the culture itself, which is a big deal, and it takes time to change, how do you present the definition of safety at a different organization, and to whom you present it?
Okay, so yes, this, as you heard, is an extremely large organization, and I think we use a model that is a tight, loose, tight approach, right? So we know how to personalize the concept. As you said, it's part of our culture, and it means different things to different people. So we're very thoughtful about being consistent, but the application really is geared towards whatever hospital and campus we're leading.
In addition to that, from a system approach, whether it's a performance improvement quality group that sets a dashboard with expectations and measurable metrics and goals that are trended not only within our organization, but our region and nationally, they then are cascaded down to a more local dashboard with the same intrinsic values and measurements, but then, to Nicole's point, it really concentrates depending on that location. Meaning that campus. Furthermore, as we get deeper into that campus and within the walls of that specific location, we have collaborative care councils, we have local safety teams, we have PICG, again, as a local perspective, and that buy-in cascades to what we mentioned earlier, from the CEO to the presidents of each of those hospitals, the safety and quality leaders locally, our patient advocates and family council representatives, and then all the way down to the local. Every shift, there's a handoff. We have a safety stand down in our ORs. We have a handoff communications, and we also have weekly safety rounds. So we're constantly cascading the message of not just safety, but any of those experiences that have been brought forth from either the week or the days prior.
This is great.
I would say also our leaders at the system hospital, we are all rounding, and we're going to talk about patient rounds, but we round to connect with patients. For connecting with employees, we can round on a purposeful topic, or we can just be rounding because we are looking to connect with people and understand what's driving them today. You know, this week we're celebrating Patient Experience Week. We're rounding and saying thank you. And when they see you often, they're going to tell you that, hey, I'm worried about this in the parking lot. There's not enough light. And you may say, oh, I didn't expect to have that. But you know what? We know the right person to give that to, and they can assess the situation. So I think that we're so lucky that our president and CEO, he can round any day of the week. He can come in 5 minutes and be ready to round, and we're going to take him. And I'm going to round today because I want to look at what's going on the floors. I think that's a really key variable, that we're out and about.
And again, just not only for safety, this is not a daytime operation. Obviously, we all know healthcare is a 24/7 operation. These rounds do not just happen during the day. They're happening on evenings, off shift, weekends, holidays, because of the inclusiveness and the specific differences of how operations and the impact that we have for our patients and our family members, as well as our team members, that happen across not only the calendar, but the entire clock of the day.
No, it's very encouraging because today I looked at Newsday, which is a local paper, and it stated that 7 of our hospitals received an A for safety from Leapfrog, and the rest received Bs, which is very close, really. It's a fraction of a percentage. So it really support or reinforce what you're doing in this great organization. So my question is that how do you implement the culture? I mean, we see the evidence, obviously, an objective entity wrote about it, but how do you do that?
Yeah.
I think you said a lot, we've talked a little bit about structure, right? We do have safety, performance improvement coordinating group, and we have the hospital performance improvement coordinating group, and that goes to our medical board and to our board of trustees on the safety measures, the things we identify and do risk assessments on. So we are all measuring the same thing, and each hospital has the same information going up, and then we can learn from each other. So if something's going well with a utility project at one hospital, we can bring the lessons learned back to here. Process is a lot of rounding. We'll talk a lot about that. And the outcomes is the results on the measures. But when we're even educating on safety principles, we have a scoring system that, and it's based on what knowledge you have on safety with preparing for emergencies, with fire safety, with security safety. So that's really also very helpful when you're giving people that, hey, you have an opportunity to score on a test, and it's the same questions on every unit. And I think, as I mentioned earlier, walking around and rounds builds that trust.
So basically, the human touch.
Yes.
Yes.
You want to make a comment?
Connectiveness. Yes. So active listening is critical and invaluable. Understanding what is most important to our customer around safety, whether that be psychological safety or physical safety, is something that we focus a lot on.
And this happens at every level of care, if it's a nursing home or it's an acute facility or operating room.
Very true. Every environment, and also at every level of making the connection with the individuals that we employ, right? So from our interviewing process to orientation, these are concepts that are woven in because it's truly our culture.
And in the coming slides, we'll also go with more specific details with real examples, even beyond just not the culture, the physical culture of it all and how we feel, but also the environmental impacts and how we specifically design and construct things to everything that Nicole was just speaking of. And inside the hospital, as well as in the ambulatory environment, to which Andrea spoke of, with greater than 1,000 locations across these regions.
Yeah.
Okay. So we are going to the process now. And it's a very interesting slide. It talks about individual, which is, I assume, the professional and the patient. And then you have the group and the social environment, which dictates the interaction between the two elements. And then the background is the situation, when it happens and how it happens. So in other words, in the operating room, the dynamic may be different, then you go to regular medical flow. So anyone wants to make a comment on that?
Yeah, if I may, we'll just start off. I think this is a very simple but powerful slide to represent all these contributing, interconnected factors that then at the end come out with a safe process. And there's 5 key things that come of that included in that safe process. We have increased motivation. We have enhanced and greater consistency. We have resiliency about this. We have a positive and a proactive approach. And then, of course, overall, we have a positive influence. And really, one of the key things I'd like to focus on is specifically about this is increased motivation. And Nicole mentioned it earlier, is that when safety aligns with the values, we're driven by internally. And that intrinsic value is really, it's about acting safely rather than having influences from the outside. It's intrinsically you feel it, and your core values is the fuel to motivate why and how you're making certain decisions.
So intrinsically, it's an attitude, right?
Yes. Yeah.
So how do you take what is 20,000 employees and make them to have the same attitude? It's so complex and difficult to implement.
Yeah, we talked a little bit about being proactive, and I think expectation setting is really important, right? So our culture is our culture, and that's our bedrock, and we really focus on personalizing, but at the end of the day, there's those values that we don't veer from.
So those expectations are set upon orientation.
I would say even earlier in the interviewing
Okay.
process.
Very selective in regards, first, if we come back to by maintaining these core intrinsic values and making sure through positive influence that we have the right leaders that are in place, we're then entrusting that their decision capabilities are able and enhanced to then identify like-minded and will-minded individuals as during the selection process called interviewing, to then identify individuals that have that same core intrinsic values as part of who they are. And then being incorporated and welcomed into the Northwell family as a team member, makes it much easier to then transcend those messages across how that how that team member is going to share their values back again to the organization, but then also to our patients.
So human resources plays a major role.
Oh,
It certainly does.
It does.
The concept that engagement is so interwoven into safety and experience.
So the culture, the whole idea starts from the very, very, very early.
Correct.
This is how you can change organization.
You make reference about being very complex. The best example that comes to my mind is like the Philharmonic. Everyone there is very talented, right? But if everyone works individually without a common mindset and a maestro, it would never sound the way it does. And here at Northwell, the values and those intrinsic safety kind of aura that we have and that we instill creates that Philharmonic type of environment.
Yeah.
Which is our shared mental model.
Exactly.
This is great. And of course, the head of the orchestra, the conductor is Mike Dowling, am I right? The CEO is the conductor.
Yes.
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 On the
yes.
enterprise level.
Right.
Yes.
What I see, though, from my quality seat on this slide, is I could put up our just culture and root cause analysis.
Oh, good.
Okay, because when we look at just culture, we look to see about, did the individual make an error and did they intend to? And, how can we support them if something happened? And we look at, is the system designed properly for us to have a safe process? So oftentimes it's both the system and the individual, which I think is the group and social piece of this. So we have to really make sure we have a stronger system fix for preventing what we're looking at. So I really see that, although this is about values and the process, from a clinical quality point of view, it's very complementary as well.
This is great. So the medical staff follows the same process.
Absolutely.
So physicians and allied healthcare profession and nurses play a major role in implementing safety, in particular the culture of safety, because they are around the patient 24/7. And they have the immediate interface with the patient. So it's extremely important that they are part of it. And to illustrate how they are part of it, as you can see in this slide, it's called real time, where data is being provided for the whole organization. This is only a glimpse about what is happening on a daily situation on the floors. If patients fall, if there is a long turnaround time, in the operating room. All of this has an impact on the outcome and the process of safety in this immediate environment. And what is so important about this type of data, it's not that it's colorful, but the people who look at it need to understand it. You need to be able to read the statistics. We give a universal approach for the whole organization, immediate snapshot. And then if you look to the right, you have detail. So it's on different level of care, different units. We know information like critical care, to telemetry, to women's health, and so on. And this is important because the information now are being transferred to the unit. So the people on the floor, they don't need to be specialists in statistics, but they need to be literate in statistics. So they can read it, interpret it, and act upon it. Do you have a comment, Andrea?
Sure. I agree. This is data for the floor, and this is frontline and management team. But for me, if we get a call that we have to enact a command center for an emergency, water main break, this data will be helpful to me to know what beds we have available, what this impact is, and where we need to move patients to, and to work with our safety people on let's mitigate that situation, but then also turn to our experience and patient family centered care to say, let's start communicating. We have a problem and we want to manage that problem. So this data is so helpful that we have it 24/7 available to us.
In every organization.
It is in every organization in different ways. I
Yes.
think that we just opened a hospital operations center, so I think our data is paired with our needs that we
More
identified
robust.
here, and maybe more advanced in how we present it.
This
but
is fine.
we, being part of Northwell, we're going to share our
Yes.
methods.
But data is data, and everyone can look at it and understand it. It's like reading a newspaper.
To really tie all this together, on the previous slide, that funnel that clearly demonstrated individual, group, and social, as well as situational. The example that Andrea just gave earlier about a water main break or any type of
Yes.
emergency situation, how does that always tie back to safety? It depends on the situation, but right in front of us, we have real-time data that allows us to do a pulse check on whether a unit, an enterprise, or a campus.
So the next question is, how do you get input concerning safety from clinicians? This is a very important concept because they are the ones to be in charge of the patients. Anyone want to make a comment on that?
Sure. I would say the very first step is cultivating that trust. And how do we cultivate trust? We have to take a multimodal approach. I think it's very important that we do many of the things we've discussed today, right? It's active listening and it's setting expectations.
It also resonates through a just culture, right? You speak more freely and easily without any type of punitive actions that based on whatever happened in the past. So by self-reporting, doing it, we have on a regular basis across the entire enterprise a safety culture survey to which individuals fill out the survey electively, and we use that, going back to your point about data, to concentrate on opportunities that are existing today, but then moreover, our lessons learned, whether it's on how we design something or a certain type of outcomes or any emergency situation. And after action is performed, and then we tie that directly back to a just culture.
So if I had to summarize a little bit until now, what I'm learning is that setting expectation is number one by the organization. Number two is to figure out how to count through data and present and communicate through data. And the third is communication, which is a multidisciplinary. So what I see, the model of a collaborative care council. Can anyone make a comment on that?
I think, building on what you said and what Nicole said, this model, and we call this our care model, establishes trust. And the council is that shared governance, that all these disciplines that you see on the slide meet at a local unit level to improve environment of care, patient safety, employee concerns, patient experience. So their input matters, and that collaborative council is getting a voice in our hospital performance improvement coordinating group every month. So we know that their priorities are aligned with our priorities. What I think is really special about this model, and this model is across the system, is this is the rounding model that we use daily. So the people that are in the blue boxes, the nurse manager, physician leader, and the green case manager and social work, and the purple with the advanced care providers, are everyday meeting, 7 days a week. And they're discussing what's going on in the unit with each patient with their plan of care. And you know what? That may involve something related to safety. This model is the crux of how we deliver care across the system.
It's great. It's a wonderful answer. In addition to having this type of a structure where you get communication on a daily basis, you also look at your population through analysis, and you define areas of concern. So here you did an analysis on the population that Northwell serves.
The old Northwell.
The old Northwell. In other words, without 8 hospitals.
Yes.
But what is interesting about this data, that it shows that the population in general of the elderly is increasing.
Mm-hmm.
And not only that it's increasing, the type of services that we provide focuses on this high-risk population that are problem-prone. So this is a very impressive slide, and I'm glad it's here. So this type of information, where does it go? In the Performance Improvement Coordinating Group?
Yes, I think it goes a lot of different places. I think that the health system really looks at how we can care for our community as a whole, and they have really a great work on community needs assessment, and they have population health and very centric departments that really look at our population and how to care for chronic disease, how to look at social determinants of health. So that's really wonderful, because we at hospitals partner with the screening and identifying the needs of our community, and also through data look at what diseases we need to educate our patients on. So we may have a transplant program here for kidney, but I know that downstreaming is education on hypertension, okay?
Yes.
But in this particular illustration is really looking at those patients that are over age 65. And I'm happy to say, ahead of the government expectations at the CMS level, are looking at age-friendly care, right? So we're looking at building on what our nursing teams have done across the system with the niche model, but we're really breaking it down, and this is where we're really learning from best practices that are happening across the health system, how to better care for age over 65 and what matters to them. What's their mobility? What's their mentation? What are their medications? So we can have our people that are close to these processes really do a risk assessment on how to make things better for that population. And Nicole and Anthony and I are very involved in looking at age-friendly care.
And you focused as a result on the geriatric medicine.
Correct. And personalizing to the population. This is a design-specific opportunity for a population that we really need to be thoughtful about.
I was trying to simplify it by one size does not fit. One size does not fit all, and something we're very, very proud of, and that it's really hidden within this slide. This calls out just a population of 65 and greater, right? What does safety mean? You asked us earlier, what does safety mean? Safety means so much, and so much different for each age group and population. Whether you're having a newborn, what does safety mean? We have concentrated efforts through collaboration, best practice, and shared model about how to create a safe environment. 65 and older, which we're concentrating on this slide, which is in our region rising and faster than even the birth rates. So this is why we're calling this out. But what does safe mean? And we're very, very proud that it is a multimodal approach in which it's not just a set regimen, but yet it's augmented specific to the social, economic, but cultural, but also the age population.
Perfect. So this leads to the next slide where we talk about the 9 plans. And I'm really happy to see that it's all patient-centered. Person-centered.
Every decision is patient-centered and person-centered here.
So for the elderly population, this will apply slightly different than for the young population.
Of course. And what's unique about this, and for everyone that's participating in this viewing, is that the Joint Commission is really focused on 7 management plans. Here at Northwell, we took one step further because whether it's the 7 plans, which are really at the top cresting part, but if we concentrate right now on the bottom 2, which is workforce safety and business continuity, we added those in as additional plans because one plan and safety, as we mentioned earlier, can never encompass everything on this slide. So with more granularity and specific to those aforementioned things of psychosocial, community, cultural, and even campus, or as Andrea was saying, specific to lung transplant or heart transplant, each one of these have a tying back factor to safety that is specific. And we just added in workforce safety because without a workforce, and then everything that Nicole mapped out earlier, we're just really a building. The workforce is really what makes it healthcare.
So we did learn how to get input from clinicians. And now is how do you get input concerning safety from patients and their families?
Sure. So the theme certainly has been a thought of being proactive, and that is why we have such a heavy focus on community partnership. So as you can see on this slide, we really thrive on making partnerships with the community, whether that be our influencers, our faith leaders, our government officials, our prior patients and families. We need to understand what is most important to them so that we're able to provide that education. Wellness is something that Northwell really focuses on, and well-being and preventing our community members from coming back or coming to the hospital. So it really starts before our patients and families ever get to an inpatient facility or campus. Should a community member need to seek care here at North Shore University Hospital, we are very thoughtful about real-time feedback. We've spoke a lot about rounding, and our clinical leaders are expected to round. In addition to clinical leaders, we also have experienced leaders who round, and they leverage technology. The tool that we use is Cypher, which helps promote communication from shift to shift, as Anthony mentioned. This is not a 9 to 5, but we have to be able to really thread what is important to each of our patients and their families throughout 24/7. We also have, and we'll discuss later on in the environment of care, really been thoughtful about selecting and curating technology that's static in our patient rooms. We're able to really get the feedback from our patients, even if a human is not there asking the question at that moment. And then, of course, as you've heard, our team member feedback. I'll then take it a step forward to talk about the post-discharge experience, or just the community partnership at large once someone leaves our campus. Obviously, There are surveys that we're able to provide to our patients and families. It talks about the hospital environment. It asks how clean. Our goal here at Northwell is to be in the 90th percentile, which we're striving and getting very close to. But not only is it the surveys that are important to us here, it's really about how we make people feel. And that reputation to us is what really makes us most proud.
Great. So basically, you professionalized patient complaint.
We turned the model.
Right.
We went from a complaint-centric department and concept to being proactive.
This is great. So your position is a new position.
It is. I think
So
it
could
speaks to
you-
the investment.
So could you describe it a little bit?
Sure. So I think you said it perfect. I started in this industry about 13 years ago, and it was a complaint department. And we very quickly said, how can we be viewed as a trusted resource, not only to our external community, but to our internal community? And that means our clinicians, our nursing team, anyone within the building. And with that trust, that provides psychological safety to allow then for an experience that is safe for our patients and families.
So can you repeat your title again?
The Vice President of Customer Experience and Community Partnership.
Wow, this is really great. I really love it, and I think we really professionalize communication.
Communication is key.
Instead of simply talking, there is action involved, interpretation, and expectation.
We synthesize data here, right? We're really proud of the opportunity to humanize those numbers and complement that with the feedback.
Right. So your partnership in this endeavor called healthcare delivery system had an impact on the environment, the physical environment. And this illustrated very nicely in the creation of a new wing in this organization. So would you like to make a comment on that? Anyone?
Yeah, before we tie back into the local side, on the previous slide, we called out two main things: team member feedback and post-discharge. On the facilities design, safety, crisis, emergency management, business continuity, all those about the 9 plans that we mentioned earlier, we use our team member feedback and a post-occupancy to catapult us into how are we designing, constructing an environment, that environment of care for the next, whatever the next project. And the Petrocelli Pavilion, which was being called out here, a lot of information, synthesizing that data from collection of concerns or opportunities post-occupancy from previous projects have allowed us to use a best lessons learned and really to forecast using the direction that we're looking to go in, but also if there was an opportunity that was discovered 6 to 9 months post-occupancy on other projects, how do we learn from those lessons? And it's really about getting our patient feedback and synthesizing that, getting our team member, the care providers, radiology, transport, those that are having direct and indirect patient contact and communication, and then putting it all together to create a project like this.
I just want to remind everybody that this new pavilion has 18 new ORs and over 100 ICU beds. And what Nicole's team does with the community and our patients and our team is engages them. And if we're going to have a change, such as we did moving in this on Super Bowl Saturday last year, we need the people to be engaged and ready to do it. We didn't say we're moving, this on several different days. We picked one day and we're moving in. And you need everybody aligned. You need everybody really understanding the purpose. And it's because of the activities that we do and going out on the floor and talking to our team members that they trust us, so that this move was very successful. But the design of this, I think, Nicole and her team had a lot to do with, and that was a great partnership with safety. I don't know if you want to add anything.
It was years of planning. What I'll say is we certainly got to a place where we moved in one day, but it was thought out and executed in a way where we really put the expectations of the individuals who would be working in the space first, and then, of course, our patients and families. We had simulations. We asked them to take Post-its and really place where would be most realistic and beneficial for our team members to have these things so that it was viewed as an improvement. And I think that really speaks to our lessons learned. We want to improve. And when our team members see that we're taking action, that's another way to cultivate trust.
And using safety is not just it's not just a word. Safety is truly an outcome. And that outcome is an environment. An outcome is planning. An outcome is input and communication. We could spend hours just describing what safety is.
Everything does matter and everything ties back, and it comes down to the way we design things. So it was extremely, very, it's nice to get a new building, but it's nice for it to get all the input.
So, Anthony, as you said, you mentioned earlier, the next slide really captures what you did.
I think we are transparent. I think that in the OR, we really encourage and know we have a safe environment because the important processes such as the timeout, we have revamped, and we do have a process that it is recorded, so we are graded by someone who's on the camera, letting us know that we were successful in that sign-in, timeout, and at the end of the case, sign-out.
Right. So to make an error is diminished because the information is there. So plus the team, the participation, the awareness, and this information really helps to reduce errors to almost zero.
Absolutely. But I do think as we talked about, you have to prepare. You could be
Yes.
in the OR and your temperature and humidity is not okay, and you as the provider
Right.
have to do a risk assessment in a really quick way to do what's best for that patient.
Right.
So I think that drilling things, learning when events do happen, makes us have a safety environment in whether it's the new OR or the older legacy OR.
Right. So you like
I think this is a
so-
summary of all that's been discussed, and what
Right.
really makes it a thoughtful approach.
So when you talk about biometrics, what do you mean by that?
In the past, we didn't have vital signs
Right.
integrated into the medical record, and now we do, and you put
Correct.
the reader on the person, and you get information about their sugar and everything you need to know about that. I think what the new building is, when you get that, it's a chance to test new technology, and I think that's one of the advantages of having the different ICUs there and the OR, that we are able to test this out. And at the end of the day, if the patient's able to, they're our partner. So if we have a communication device that we're using for them, they're letting us know this was great because I was able to use this iPad and my family could see me, and they knew I was out of my transplant, or they now see I was extubated. So there's so many different technologies that we're testing to learn and make better, and I think that's the power. If the technology ends up working in our ICU, Northwell can adopt it
Correct.
at other ICUs.
So because we are a system, we can spread it.
Absolutely.
And this is really the key. Then in the next 5 minutes, we would like to talk about the outcome. So if you look at the next slide, we have 4 best practices. And of all of those best practices, we really have maybe an opportunity to talk about one. We talked about the vulnerable population. So does anyone want to talk about needle sticks? Because this is a problem that exists in healthcare for at least 30, 40 years.
Sure. I think that needle sticks, we're very lucky at Northwell because I think when we train providers, they start in the EMS. And I know you grew up in EMS services, Anthony. And so to start the training for wherever you work, especially in EMS, to prevent needle sticks is really important. What we've done, though, now is instead of making them go to a class on preventing needle sticks, is we're going out to them, whether it was in the EMS, whether it's on the floor or in that new pavilion. We go out to them, we show them how to avoid that needle stick, and this way they can tell us, well, that device snaps and I don't want to use that. So we get feedback on the equipment they're using, how to make it safer, and then we're educating them as well. And as you said, we have data on needle sticks that we are engaged with our employee health services. So every month we get, are we up, are we down, and where are they occurring? This month, unfortunately, we had a few more in EVS services than we did in other areas. So like now we're going to target why that's happening. So it's always going back to the why and preventing. But the process we've established when there's a needle stick to get tested and the instructions around that, I think, is also good. So that's a good story. I do want to come back to the vulnerable populations because we really did a lot of research with our quality team and our patient family center team and our crisis management team to really look at those patients that can't hear. That if we have a fire alarm, they're not going to hear. Or those patients, if we have to evacuate, that can't see. So a lot of awareness education came out to know who those patients are. But then how do we make them feel comforted by what we need to do with the rest of the hospital, whether it's evacuate or close the door? They don't know why because they can't hear it. So we really are working on a whole education for frontline providers to really, it's not only the deaf and the blind, but people with disabilities. How can we make things better? So I'm really proud of that work.
This is great.
And though we can not go into every specific best practice, I think a way to sew this together is to talk about immersive experiences. In all these areas, when we at Northwell provide immersive experiences for our team members or for our community, it really propels us to understanding in a deeper way.
This is great.
And I think really pulling all this together is one of the approaches that we've been using is what we call is the 3SP approach. And really what that comes down to is how do we create standardized, sustainable, safe environments using people, process, and partnership.
There you go.
That is truly how we pull all of this together.
This is great. So since we have only 2 minutes, can anybody make a comment on looking ahead? This is the last slide.
I think we want to continue to look ahead, but I think the method that we're using, building on what Anthony said, like sustainability, started at the system level because we can reduce gas emissions. But the recycling efforts and the bike drive and the gardening efforts were homegrown by frontline team members. So when you look at the sustainability initiative, you have managers and frontline staff driving that. And we're inviting them to leadership meetings. And they got invited to do at our hospital quality performance improvement meeting, our senior operations meeting. And because their work is so meaningful, they got invited to share it across Northwell. So I want to say we want to continue the methodologies and get the frontline team members to continue to drive as well.
Wow.
And they might have some things to say too.
Any comments?
One of the questions that we ask on an annual basis with our team member engagement survey is, do you have the tools you need to do your job, right? And for many people on a very one-dimensional, a tool people may feel is a pen or a hammer. For us, a tool is really, do we give them the right environment? Are we giving them the right education? Are we giving them the right surrounding overall culture for them to thrive and work at the highest level of not only their licensure, but of what their team expectations are? And through a culture of safety, and as we continue to say what that outcome is, that carrot at the end, while this slide says it's the next exit, this is just really, where we're going for the future. We're not exiting anything. We're just taking a different approach with measurable outcomes, and we're capitalizing on where there are opportunities, and we continue to measure it with never settling. To Nicole's point, we thrive to be at the 90%. We will be at the 90%. That's not the end. That's just the beginning of what the next chapter is.
we're comfortable with being disruptors, and we don't want to settle for the average, right? We really want to be able to provide what's best and most meaningful.
Yeah, so thank you very much for your input.
Thank you.
It was absolutely brilliant. I find that patient safety in the environment of care really changed dramatically since my time. We focused more on regulation and expectation from regulatory environments, and now you're doing it on your own. So it's really the opposite. You do it on your own, and then you present it to the regulatory environment. So you're taking a proactive approach, and in fact, as a result, you can shape regulation.
You built on the baseline.
Right.
So again, thank you very much.
Thank you for
Thank
the
you very much.
opportunity.
Thank you. Okay, we will turn it over to Be Live for questions, and we thank you for the recording. Okay, we can go live. Thank you.
Everything's there.
Well, we're here for any questions. If anybody has any? Yeah.
Okay.
If there's no questions, we'll sign off. Thank you, Bernadette. Thank you to the American College of Medical Quality.
Thank you.
Thank you.
Okay.
Bye.
Bye-bye. Yeah.